नहीं नहीं हाँ, ठीक है चार्जर वहीं पे Good evening, everyone. My talk is on unicompartmental arthroplasty and its outcome. I'm Dr. Manish Sharma from Odisha. Unicompartmental arthroplasty is a surgical technique used for treatment of end-stage osteoarthritis in one compartment of the knee, most commonly in the medial compartment. UK was first introduced in 1970. Despite growing evidence in favor of worldwide, only 10% of the orthopedic surgeons perform UK, and even less number of surgeons are doing in India. UK makes up to 8.6% of all primary knee arthroplasty, among which fixed bearing designs have demonstrated a steady rise in increase from 17% in 2003 to 40% in 2016. Technique for implantation of fixed bearing designs is technically easier than that of mobile bearing devices, especially with regard of ligament balancing. So whenever we talk about indications and selection of unicondylar knee replacement, we will always talk about Cosin and Scott criteria, which was derived in 1899. They said isolated middle compartment disease only, age less than 60 years, low level of physical activity, weight less than 82 kg, cumulative angular deformity less than 15, correctable varus less than 5 degree, both cruciate ligaments should be intact, pre-operative range of flexion should be at least 90 degree. Flexion contracture should not be more than 5 degree. No radiographic or intraoperative evidence of chondrocalcinosis. Lastly, the patient should not have any inflammatory arthropathy. So current opinion, including Oxford group, they said prior to considering surgery of UK, patient should always have attempted treatment with conservative measure, including activity modification, physical therapy, anti-inflammatory medication, bracing, and or injections. Patellofemoral osteoarthritis is not an contraindication anymore. Age is not a limiting factor. Obesity and high BMI no longer strict contraindication. Although mobile bearing devices should be avoided as it leads to frequent skid off of the implant, poly. ACL and MCL that are functionally intact and full thickness cartilage should be there in contralateral compartment. Active infection, inflammatory disease like rheumatoid arthritis, ligamentous instability, or MCL contracture, absence of ACL, history of STO, they are still contraindication for UKR. There are certain consideration that we should look for. Knee has three compartment, medial, lateral, and patellofemoral. Medial compartment comprises of medial condyle and medial aspect of the tibial plateau, lateral condyle and lateral aspect of the tibial plateau, and PFJ. Patient can develop arthritis in one knee, one compartment or two compartment or all three compartment. The alignment of the limb is one factor that can determine the location of the osteoarthritis development. For example, people having bow legs will develop arthritis in middle compartment. People having knock knee will develop arthritis in lateral compartment. So choices of implant. We use Striker in our setting. The single radius design of the Striker Triathlon PKR was developed on the success of total knee replacement design of the Striker Triathlon. It is a it is a cemented processes with a separate insert of variable thickness made of X3 highly cross-linked polyethylene. The femoral component is designed to tolerate coronal alignment up to 10 degree varus and valgus without causing edge loading on the tibia bearing surface. Both tibia and femur component have two pegs to aid rotational stability and fixation without need of generating additional large keel. There are other consideration in UK include the use of mobile bearing versus fixed bearing implant. Mobile bearing implant were introduced in 1980 and were designed to distribute load over large surface area to decrease the polywear. But modern fixed bearing implant are characterized by low conformity between the femur and tibia component that permit greater range of motion, decrease wear. Long-term outcome in the literature have failed to demonstrate superiority of one type of bearing over other concerning implant survival and patient outcome. However, with cemented and uncemented, there is limited exposure. Short and mid-term follow-up has shown similar survival rate between cemented and uncemented bearings. Surgical techniques is a busy slide. I'm going to skip this. Advantages of UK, there is a strong evidence that patient who undergoes this surgery, as it is less invasive, have a reduced risk of periprosthetic joint infection, lower overall complication rate when compared to TKA. Faster recovery and rehabilitation while still achieving comparable result with TKA. Recent studies have highlighted the advantages of UKR over total knee in patient with medial compartment osteoarthritis, which include reduced blood loss and the risk of transfusion, better restoration of physiological gait pattern, shorter LOS, reduced readmission within 30 days, better patient-reported pain and function scores. So UKR versus TKR, the study which says there is a 90% of survival rate in UKR within 10 years. So furthermore, a match comparison of UK and TK based on NGR data, including over 1 lakh knee arthroplasty, demonstrated that major medical complication such as thromboembolism, infection, stroke, MI occurred between quarter and a half times less frequently in UKR. Moreover, the mortality was significantly lower in UKR. However, the revision rate of UKR was 2.1 times higher than that of TKR. In a further matched study, 15,000 patients from the National Joint Registry, they reported superior outcomes of UKR than TKR. However, unadjusted data from NJR shows significant high revision rate of UKR than TKR, with the chance of revision of UKR at each estimated point of time being more than double that of TKR. A higher revision rate was also confirmed when patients were matched. UKR had worse implant survival than TKR at 8 years. So it's a patient testimony, one of my patient. We did medial UKR for AMOA. Patient walking with and without support on day 1. Okay, there's another paper. It suggested quadriceps and hamstring muscle strength improved after unicompartmental knee arthroplasty, which improved 39% and 26% for quadriceps and hamstring strength respectively. Better functional outcome and better post-operative range of motion with UKR. Another paper, it said largest survivorship and clinical outcome study in fixed bearing striker triathlon partial knee replacement. It's a single center study performed by multiple surgeon, cohort study with minimum of 2 years of follow-up. They all support UKR is better than TKR. When it comes to lateral compartment arthroplasty, UK, we should always support a fixed bearing implant as a lateral mobile bearing implant in lateral compartment has a high risk of skid off. One of my case, bilateral UKR in one setting of lateral compartment. Complication, the most dreaded complication is medial tibial plateau fracture. In the literature, several measures were proposed to minimize the risk of MPTF. One of them, appropriate patient selection and low BMI. In these complications, ORIF was reported to bring favorable outcome, being less invasive than revision to TKA. Up to date, different method of ORIF were not directly compared. Complication of UK, one study suggested 9.8% of complication, which was very, very high. Among most of the complication were due to polydislocation followed by degenerative osteoarthritis on the contralateral compartment due to malposition and overcorrection. MCL rupture, a septic loosening, proximal tibia fracture, and ACL iatrogenic injury were other causes. UK mode of failure in conversion to total knee arthroplasty. Although incidence of failure is greatly diminished with large generation of UK bearing dislocation, polywear, mechanical loosening, progression of osteoarthritis continue to affect the final survivorship of the UK. Converting to UK to TK is very complicated than performing primary TK. So take home message, UK treatment of osteoarthritis in one compartment of the knee, most commonly in the median compartment, more closely mimics the normal knee kinematics, lower perioperative morbidity, increased demand of minimal invasive approaches has led to increased popularity of the UK. Robotic assisted technology has improved surgical precision and component alignment in an effort to increase survivorship. Higher incidence of failure and revision of rate in UK, especially in the early period, has been often attributed to incorrect clinical and radiological indication in combination with surgical error when performing UK. An ultimate goal in UK surgery, therefore, is to reduce surgical error by performing a certain number of cases per year, ideally to combine with a technology to reduce malpositioning of the implant. So we are living in the era of memes. There's one for you guys. More and more young surgeons are getting inclined to UKR as complications compared to TKR is less. Thank you very much. Thank you, Ashish sir.
Thank you, Dr. Manish. And that brings us to the end of today's sessions. Any questions? Okay.
So, with the rate of revision at every stage being double that of TKR,
Yes,
and with the technology and the implant of TKR improving, survival rates matching around the THR, is it justifiable to do UKR still?
Sir, that onus lies with the surgeon, sir. It is on our, it's our responsibility to see the criteria and uh, select the right patient. But when we compare complication rate, UKR is giving better result than TKR.
No, with complication rates, UKR is not giving.
But revision is definitely much more higher
Isn't
than,
it? So-
especially with young surgeons.
So initial rehab is less, functional outcomes slightly better in the first 6 weeks. After that, both are matched,
Both are doing same.
but complication rate and revision rates are still double that of TKR.
Yes, sir.
Isn't it?
We have to agree on that, sir.
Okay, thank you very much.
Thank you, sir.
I thank you, the chairperson, sir. May we have a group photo, please? So with this, the session, the end of day one. And today, I would like to invite everybody for the gala dinner. Satish Kajmer, a very famous Saregama winner artist, is going to be here, along with Soulful Saga team. Tradition of Bihar, Ma Ganga Aarti is going to be shown. And you'll have a wonderful evening. That's what I can promise before even the start of it. So with this, I close the session all for today. And we'll take a break. We'll get the hall ready. And we'll have that evening dinner would be, this evening will be followed by gala dinner. So practically the dinner would be in where we had lunch, that is Kesaria, and the music will be here. So you can have your dinner, come here or get your dinner and enjoy the music. But you'll have a great time. I'm indeed thankful to all the chairpersons, sir, all the faculties, all the guests, all my colleagues, all my mates for being here, and all the persons from the pharma companies. I'm indeed thankful to them. And if you have time, please also visit the stalls. So they have been immensely helpful for arranging this sort of conference. Thank you, and see you by 7:30 p.m. tonight. Please come with families if possible, sir. अब मजा आएगा शाम में बता रहा हूँ एकदम फन होगा Dr. Suman Das sir, it's all stage is all yours, and the time is approximately